driving ethos behind PQIP is to allow local teams to track their performance, their processes, their outcomes over time, and see what's happening in their institution and improve locally.
So now we're going from a point prevalence type study, which is NAP2, into something more longitudinal.
So I'm going to look at sort of different factors which impact upon that, and there's a big drive from the Department of Health and all the august bodies that clinicians should be taking a greater role in leadership in hospitals, and as part of that they should be driving improvement efforts. But we also know, on the other hand, that the NHS is bursting at the seams and clinicians are just running to stand still with delivering clinical services. So whether they have the capacity to do this kind of thing, I think is up for question. So that's some of the aspects I'm going to look at. 10 or 20 years' time, we'll look back at where we are now, and we're gathering lots of information piecemeal in different systems. If we put it together in one repository and shared it internally or externally, it would be fantastically useful. And I'm not the first person to notice that sort of data and IT linkage in the NHS is not optimal. People are anxious that the workload is prohibitive and they won't be able to engage with PQIP. But so far we've found the sites that engaged actually have not found it too onerous, and they've been able to collect the data. And I think when they start seeing their results in a useful...
Getting the data back.
Getting data back, and we're trying to ensure hospitals get their local data back, which hopefully will make it more real and more rewarding and more useful.
But when they introduced the cardiac league tables for cardiothoracic surgeons, that people started taking less risky operations on because they didn't want to have their numbers affected. Do you think that if we're publishing institutional measures of performance, a similar sort of thing will be happening? People will be cherry picking their patients?
So our aim is for local sites to track their processes and measures over time, not to compare hospital A with hospital B. But we recognise that it can be useful for sites to know where they sit. The current feeling is that we will allow hospitals to compare to each other or to a national average on their processes, because I think that's less contentious. I think the outcomes are going to be risk adjusted, and we will have to sort of suck it and see with how we go with benchmarking. But I suspect comparison to national average is where we will end up.
I think that might be an interesting question for the ethnographic sort of study, whether or not people on the ground would like to be benchmarked.
And in a way it's a contrast between quality assurance and quality improvement, which sounds a bit geeky, but assurance is just guaranteeing to senior
management,
a minimum standard to senior management, and then to regulators and to patients, that this hospital is delivering a minimum standard and safe care, which is important. But that's been the emphasis really on regulation, as far as I can see, regulation and governance so far. And in fact, that just gets you above the minimum bar. It doesn't necessarily get you improved, get you further forward.
Sites which participate in research seem to have higher performance. Do you think that we will then reach a point where the sites who engage with PQIP are a self-selected bunch who will actually improve because they are eager to engage with things like PQIP, and then that might influence other sites to participate? It's sort of a positive feedback system.
Possible. In the US they've had a system like PQIP that's been running for 10-15 years, and they actually did a study comparing outcomes between the sites that were participating and the sites that weren't. And to begin with, the sites that participated I think had better outcomes than those that didn't. But in the most recent paper, which was a couple of years ago, there was no difference. And it's potentially because you generate secular trends in the healthcare sector where
more globally,
where you have a significant minority or a small majority moving policy and practice in a certain direction, and then everyone moves with them, which is a great outcome if that happens.